So, welcome to our little morning adventure. Congratulations for getting up. You get your awards for being almost a surgeon. Oh, my goodness gracious, this is so early. Now, we have the purpose of this thing is we try to pick three areas that would highlight areas of controversy or novelty. So we're going to go on to the first. We have three speakers. The first is Richard Bachman. He is the chief of the endocrine service at the Hospital for Special Surgery. And he is going to talk about the issue of male osteoporosis. This is probably the only area in which men are second stringers. And the point is that they are out there, they're difficult, they have a much higher mortality rate, and we think that they're often neglected for whatever the reason is. It's very hard for a male to say, I have got osteoporosis. But we'll go over the implications and where we're going. And now there's a lot more data, particularly at the meeting today. This week, we've seen a lot of information in that area. The second speaker is going to be Emily Stein. She's the director of the research for the Metabolic Bone Disease Service. And she's going to take what seems to be a simple topic, calcium and vitamin D, but is surrounded by controversy. What is the normals? Should you treat? What are the problems, the complications? And try to make some sense out of this, because this is a common problem. But in my case, I have a lot of trouble getting past calcium, vitamin D when the patient comes in the room, because they just keep asking questions. And we want you to feel comfortable at the end of that. The third thing is, I go to my brethren who are in the rheumatology service. When they don't have very good markers of success in treatment for their patients, so they look to function. That's an area that many people in the metabolic bone disease area have not looked at. How the patient feels, how they perform with all the things we're doing. We talk about prophylaxis. The patient says, but is it going to make me feel better? And we're going to introduce you to a thing called PROMIS, which has now become much more successful as a tool to use to quickly assess the function of the patient and if they are doing well or they are not doing well. And so this may be foreign to some of you, and to some of you may know a little bit better. And we're going to go over our experience with Kirsten Gruder. She runs our fracture liaison service and has struggled with applying the PROMIS to patients with hip fractures. Not so easy, but we've learned some lessons. So let's have a little bit of fun about this. So the learning objective is to recognize the prevalence and impact of osteoporosis in older people. We're going to talk about that. We're going to try to assess the safety, efficacy of calcium, vitamin D. This is what Emily is going to be talking about. And the implement of the PROMIS and the PROS, which may be like a foreign language to you, but when you walk out of here, I'm quite confident you will be a pro also when we're through with this little section. Okay, so we're going to have Richard come up here, and we'll start with Richard.
This morning I'm going to talk about the who, the missing man in this paradigm, and the fact that we as physicians often have to reach out to find these patients and make them aware. So I want to point out that the U.S. Preventive Task Force, which recently updated its screening recommendations with regards to not just men, but to women, in 2018. The last update was in 2011. And they point out that by 2020, there'll be 12.3 million Americans 50 years and older who have osteoporosis. And that osteoporotic fractures are associated with all the morbidities that we know about and the impairments of lifestyle and function. Now, in the U.S. Preventative Task Force recommendations, they have a B recommendations, which means it's a moderate and a recommended thing that there be screening for postmenopausal women who are over the age of 65. And they also recommend that women who are less than 65 should be sort of queried by the use of an inquiry type of risk tool. They point out that there's insufficient evidence for screening to prevent osteoporosis in men, and that bone density is accurate for detecting osteoporosis and predicting risk. They admit that. And that drug therapies are effective, but again, they point out that they're effective in postmenopausal women. And that drug therapies are also effective, but again, they point out that this is true in women. So it's time to get some answers for men, because I don't think that the U.S. Preventive Task Force is paying enough attention to that issue. So in total, there are about 33 to 54 million Americans who have not only osteoporosis, but may have osteoporosis, but also have low bone mass. And basically, they are the population at risk. And 1 in 2 women and 1 in 4 men will break a bone over the age of 50 due to skeletal insufficiency. So that's a high number. And in 2005, there were 2 million incident fractures, and it's projected to grow to over 3 million by 2025. The cost also commensurately goes up enormously, and I think 25.3 billion is an underestimate. What you have to appreciate is that 29% of the fractures, okay, occur in men, and that men are responsible for more than 25% of the cost from these fractures. So there's a major contributor to our public health problem from men. So we cannot ignore men. I feel somewhat alone on this platform being a proponent for men, but it's been my life goal. I don't know, what can I say? The interesting thing is, if you look at the percentage of total fractures and the site in which they're occurring, I want to point out that 14% of the fractures that occur are hip fractures. However, there's a very important consideration here. The elephant in the room is that those 14% of fractures, the hip fractures, account for 72% of the cost. That's a major consideration. And what I'm going to show you is that the cost for men is much greater, in the sense that there's a very high mortality associated with this fracture. Now, this is updated. I don't know if you remember. We've all seen these curves. This has to do with the population-based increased incidence of vertebral fractures. This was work that was out of the Olmsted County and by the Mayo Group, predominantly Dr. Melton, did this in 1989. The dotted curve was Melton's data, and then this is an update in 2014 of fractures in women. And you'll notice that the curve goes strikingly up. Also, it appears to be occurring earlier now in women. In men, the curve also starts to really turn up, but notice that there's a lag of about 10 years before men start fracturing. But again, these fractures, according to Amin and the updated data from the same community, is that these fractures are occurring earlier than they were before. Now, what's the reason? Why do we see this lag in when men develop their fractures compared to women? And I guess there are a number of explanations. One is possibly that men basically accrue a larger bone mass to begin with. It's higher. All right, this is based on areal bone density. And then there are differences in microstructure, which I'm going to show you. And it's still not totally understood, but it seems clear from studies that have been done, for example, in men with 5-alpha reductase, okay, and others, that androgens, or testosterone, has an important role in the early development of the skeleton. We know that estrogen is critical and is the essential hormone for bone and bone mass accrual, but testosterone probably has some role as well, not well defined at this time. Now, what I want to point out is that if you look at the microarchitectural features of bone, men versus women, is that for men, the trabecula that is, these are high-resolution PQCTs of either the distal radius or the proximal tibia. What you see is that, or what has been shown, is that the trabecula are 28% thicker in men than they are in women. And if you look at trabecular bone volume versus total volume, it's 26% greater. Now, the interesting thing is that there's not a difference in trabecular number, but there clearly is a difference in the morphology. And the other really important point is that there are significant changes, differences, or dimorphic changes between men and women in the changes that occur with regards to skeleton. Both, if you look at the top line, men and women show a significant drop with age. However, men's trabecular number does not drop, and some suggestion that it actually increases compared to women, where there's definitely a decline in the trabecular number. Furthermore, the trabecular separation grows to be much greater in women. That means the spaces between the trabecula, or that there are fewer trabeculum. And trabecular thickness both go down. So, in summary, what happens for women is that trabecula are lost and become thinned, whereas for men, trabecula become thinned but are not lost. Maybe these are the reasons and account for that delay in the fracture. And remember, those curves that I showed you originally were curves for spine, okay, lumbar spine. Here, newer data from Richard Eastle summarizing the different fracture incidences in the different structures. And this is for women, and these shapes indicate the vertebral fractures, and then the triangles represent hip fracture, okay? And these are wrist fracture. In men, you see that the curve goes up. Again, there is that delay in when it goes up. Not so much for the spine, but yes, there is a delay for the spine. There's a more significant delay in terms of the rise in hip fracture. Notice that men's incidence for wrist fracture really doesn't seem to go up very significantly with time. Kind of an interesting finding. Both of the patients show cortical thinning as they age. However, the centrifugal growth of bone, in other words, bone becomes larger, much more so for men than it does for women in the shafts of bone. This is important from an engineering point of view in terms of the moment of inertia is much greater for a larger bone. We used to work with two strains of mice, the C3H mice, which have very narrow bones but have a lot of density. And then we worked with the C57 blacks, which have a much wider bone, bigger radius. And the interesting thing is that they have very low bone density. And it's very clear that in the grand design, there were two ways to make a mouse bone equally strong, because when you test these bones, they break at the same force. So you could build a bigger bone. So bigger bones are stronger due to the moment of inertia. Now, however, even though men, in a sense, are protected in that their fractures occur later, and they may have bigger bones, the consequence of them having a hip fracture is devastating, because there's almost double the mortality, death as a mortality associated with a hip fracture in men. This is a statement that is true, but it's narrow. And the statement is, more men die as a consequence of a hip fracture within the 1 or 2 years of the hip fracture than dying from any other cause, such as myocardial infarct or from cancer. Remember, that's a very qualified statement. It has to do with the time period following the event. But there is a very high mortality, and I'm going to show you, men just don't do very well. That's why we need to nurture men. Okay? This is, I'm making a plea for men up here. This is looking, again, top bars are women, okay? And these are women in terms of different age groups, so less than 75, 75 to 84, and over 85. And what you're looking at are the control groups. This is the probability of survival, okay? And you notice that patients who have hip fractures, the survival declines. It is so impressive with men, particularly when you get to the older men. These curves sort of drop like rocks. Not a good thing. Again, just focusing on why it's important to reach out and try to identify these patients and prevent these kinds of fractures, because we do much better with prevention. And if you look at this, this is excess mortality 1 year. This is a paper that was just published in September in the JCEM, so it's hot new stuff. And you look at women for proximal fractures and distal fractures. Forget the distal fractures because there's not much of a difference. But looking particularly at hip and femur, and especially at hip, you see that women's overall average fracture mortality, excess mortality, is about 20%, much higher in men. And if you look at the older, as you get into the older age groups, this, it goes up to almost 30%, over 30% for men. Very impressive. So that's the sort of driving force, the high mortality, the fact that we could prevent some of these fractures. So it comes up to the issue that even though the U.S. Preventative Task Force is saying that there's not strong evidence to consider screening for men, when should, this is sort of my bias and also from the paper by Nelson Watts, when do we want to measure men with regards to bone density? Well, when they're 70 years and older is a good time. If they've had a prior fracture after the age of 50, I think that's a good time to do it. And if we know that they have osteopenia or have evidence of a prior fracture, such as a vertebral deformity, as you know, about 1/3 of those will be silent. Furthermore, if they have diseases or they take medications that put them, for secondary reasons, at increased risk, we do want to screen them. And screening can be fairly broad. Bone density is obviously the touchstone device that we tend to use, although there's some progress now in quantitative ultrasounds. And then I want to emphasize the fact, because the U.S. Preventive Task Force says that risk assessment tools are valuable and should be applied, and their cost is virtually zero. And the top one, obviously, FRAX, and simple ones, for example, the one developed by Merck and many years ago, the SCORE, et cetera. But there are a number of these tools that are around. This slide would take me the whole morning to describe, but I just want you to take a note of the reference, which is Looker. That paper itself will take you half a day to go over. It's totally statistics, but the meaning of this slide is that, and this was what has given impetus to the U.S. Preventive Task Force to argue that risk assessment tools are valuable, is that using a FRAX score to identify patients who are at high risk is a valuable thing to do, because you will capture virtually 95%, 95 to 97% of the patients who have low bone mineral density, either osteoporosis or osteopenia, a term that I don't particularly like. All right, so we recommend, this is my recommendation, recommend testing men who are over the age of 70, and particularly to use, where you can, DEXA as a measurement, history, physical, and to include a predictive tool. This was not in Nelson's recommendations, but to use a predictive tool as well. So just the takeaway points as we come to the last 9 seconds of my talk. Screening methods and tools are available to identify men and women at risk. The outcomes for men who fracture can be absolutely devastating. I mean, that's a hard endpoint. Death takes you there. More men die in a year because of hip fracture than any other disease-associated morbidity. Remember, that was a narrow thing, just in that 1 or 2 years post-fracture. And we have an obligation to identify and treat those patients at risk and improve the health care for these patient-related outcomes. So thank you very much.
So we're about to start with our next talk, and this is Emily Stein, our Director of Research in the Metabolic Bone Disease Service. She's going to talk about vitamin D and calcium.
So we've heard a lot about osteoporosis in men. Let's go to a clinical case. Mr. Jones is a 75-year-old man who presents after a recent fall in which he broke his hip. As part of his workup for osteoporosis and management, you'd like to evaluate him for vitamin D deficiency. Okay, so here's the question. What is the best test to order in order to assess Mr. Jones's vitamin D status? Is it 125 dihydroxyvitamin D, 25 hydroxyvitamin D, 24-25 vitamin D binding protein, or DEXA? Okay, great. So I think most people know that to assess vitamin D stores, we use the 25 hydroxyvitamin D test. Although I will say that patients that get referred to me, I see that their physicians have commonly checked a 125 when trying to assess their vitamin D status. So I think it's important to remember that that is not the best test. That is the 25. So we use the 25 hydroxyvitamin D test, but the optimal concentration of 25 hydroxyvitamin D for skeletal health is controversial. Most groups and experts agree that levels less than 20 nanograms per milliliter or 50 nanomoles per liter are suboptimal for skeletal health, and so we call these patients deficient. However, the threshold that we should use for sufficiency has been debated. The Institute of Medicine suggests that we use a cutoff of 20 for vitamin D sufficiency, but other groups like the Endocrine Society, the National Osteoporosis Foundation, the IOF suggest that 30 should be a proper cutoff. And most of the data that we have does suggest that this sufficient point falls somewhere between that 20-30 range, and this is based on studies looking at other outcomes and how they relate to 25D levels, such as parathyroid hormone, so the level of 25D that it falls below before which PTH is stimulated, or the level necessary for calcium absorption or bone mineralization, and also there have been studies showing that lower vitamin D levels are associated with a greater risk of fracture. So in terms of the optimal intake of vitamin D to prevent deficiency, the Institute of Medicine recommends 600 units of vitamin D for patients who are up to the age of 70 and 800 units for older patients. The National Osteoporosis Foundation has a slightly higher recommendation, 800 to 1,000 for patients who are 50 and older for women, and then 400 to 800 for men. Less than 50, 800 to 1,000 for men over 50. And the American Geriatric Society actually recommends intakes of greater than 1,000. And some of this difference has to do with the population that they're making the recommendations for. The Institute of Medicine are broad population-based guidelines, and the other groups are a little more targeted. In terms of dosing vitamin D for a patient who we find to be deficient and we want to increase their dose, Bob Heaney did some very elegant pharmacodynamic studies and showed that in patients who have normal absorptive capacity from their gut, that every 100 units of added vitamin D3 would raise serum 25D by about 1 nanogram per milliliter. So knowing where a patient is starting, we could actually calculate out the total amount that they might require. This is not precise, however, and his patients were sufficient at start, so it's a little different. There are some studies that suggest that patients who start at a lower baseline 25D will have a greater increase for the same amount of supplementation. And so typically, we start most patients who are deficient on a similar regimen when we're trying to increase their stores of 50,000 units of either D2 or ergocalciferol or D3 cholecalciferol weekly for at least 8 weeks, and then we repeat their levels. It's important to continue treatment for as long as you need to until the patient reaches the level of sufficiency, and also to always follow with a maintenance dose, because while the high doses will improve the patient's vitamin D stores, once they are stopped, the patients will go right back down to their baseline. And that is something that also seems to be a stumbling point for several clinicians in patients that then get referred. You can't have too much vitamin D. The Institute of Medicine suggests that the tolerable upper limit is 4,000 units per day. It's very common now for patients to be taking extremely high doses of supplements. I often see patients coming in on 5,000 units a day or more that they have initiated on their own. The earliest manifestation of vitamin D toxicity is actually hypercalciuria, not hypercalcemia. So finding a normal serum calcium is really not reassuring in terms of understanding whether a patient is taking too much vitamin D, because it's going to manifest first in the urine, and it can cause kidney stones. So it's very important to be cautious if you are repleting a patient who you know has a history of stones, has current stones, or even who you've already found has hypercalciuria. In contrast to the impact of vitamin D supplements, sun exposure, which is also a way that patients, that we can all manufacture our own vitamin D in the skin, cannot produce toxic levels, and that's because there's a check there. So there's photoconversion of pre-vitamin D3 and vitamin D in the setting of UV to inactive metabolites, and as melanin is increasingly produced, that also inhibits production of vitamin D. In terms of fracture risk, some studies have shown that there was a reduction in fractures with vitamin D supplementation, but others have not seen an effect. And there are several reasons that may account for some of the conflicting results that we see, including differences in the baseline vitamin D status of the different participants, the range of doses used, and also compliance. So in many of the studies with supplements, compliance with supplements is a real issue. Patients do not take the supplements they are supposed to be taking, or they're taking extra supplements on their own, and so things get very muddied in that respect. But in general, the studies that have seen a reduction in hip fractures and in non-vertebral fractures have seen it with doses of 800 units a day or more. In terms of falls, vitamin D status has been related to fall risk. Men and women, particularly older patients over 65 who have very low serum 25Ds, less than 10, have been shown to be at greater risk for falls and subsequently hip fractures, and that may be because of effects of vitamin D on muscle mass and strength. Vitamin D supplementation may reduce the risk of falls. Again, the effect here probably relates to the dose and the baseline level of the D in the patient. So the majority of studies that have shown a beneficial effect have used doses that were greater than or equal to 800 units a day. And so initially the thought was, well, if 800 units is good, the more the better. Let's give really high doses of vitamin D, and that will have an even larger benefit. This was a nice study. They gave 500,000 units of vitamin D annually to an older population over 3 to 5 years. And they looked at the effect of fractures and falls. They hypothesized there would be fewer falls and fewer fractures in the patients who were randomized to these large doses of vitamin D. But in fact, what they found was the opposite. So these figures show the incidence of falls is here, and fractures. The vitamin D group is in black, and the placebo is in gray. So you can see there's a greater incidence of falls and of fractures in the patients who got the vitamin D. And this was quite surprising. And in fact, what they also saw was that there was a temporal pattern of fall risk, so that the falls were greatest in the first 3 months after the patients received the dose of vitamin D. Another interesting thing about this study is that even though these patients were getting very high doses, their vitamin D levels in their blood, the 25D, was only about 50 nanograms per milliliter. So when we think about what level might be too high, it's not that high. It was only 50. So I think that's something that's important to keep in mind when we're thinking about the upper level that we're striving for with our patients. Okay, so what about calcium? The Institute of Medicine has recommendations for calcium. Again, this is an area of some controversy and uncertainty. They recommend for premenopausal women and men less than 70, 1,000 milligrams a day, and 1,200 milligrams a day for postmenopausal women and men over 70. They recommend that the intake be made from a combination of both supplements and diet. And it's important to always remember that intake, you can only absorb about 500 or 600 milligrams of calcium at once. And so these two things seem to confuse a lot of my patients. They often take all of their calcium at once altogether. They also sometimes are taking 1,200 milligrams from supplements and then additional from diet. So these are important areas where we can educate our patients and try to improve their calcium intake to a more optimal range. It's important not to take too much calcium because there are adverse effects, particularly here too, nephrolithiasis, and this has been shown to be associated with calcium supplements in studies, not dietary calcium, which may in fact even be somewhat protective. Now there's an emerging body of evidence linking supplements to cardiovascular disease. I would say these effects are also not clear yet. There are studies, many well-done studies, finding data in both directions. There are some that have shown that there's an increased risk of cardiovascular disease, MI, with calcium supplements. There's actually a possible protective effect of dietary calcium. So none of the studies have shown any increased risk with dietary, and in fact, in some studies, the patients who had the highest dietary intakes had the lowest incidence of cardiovascular disease. The difference between calcium intake from supplements and diet, if there is one, may relate to the way that they are absorbed, and that when you take a supplement, there's a sudden elevation in the serum calcium. And that may be, in a way, harmful because it may increase vascular resistance, calcification, and arrhythmias. In terms of the effects of calcium on bone density, calcium is critical during the period of bone mass accrual. In older patients, studies have shown small but consistent benefits of calcium or calcium with D on improving bone density. But the effects on fracture are not as clear. There are epidemiologic studies that have shown fracture reduction with calcium supplements, but in large randomized clinical trials and meta-analyses, when analyzed as intention to treat, there have not been effects of calcium on fracture. As I said, a lot of the problems with these studies relate to compliance and group crossover, and so in a subgroup of the Women's Health Initiative, when they looked at what the patients were actually taking and analyzed it that way, they did see that the patients who were taking calcium, that was related to a lower risk of total fracture and of hip fracture. And then this was the recent JAMA meta-analysis where they looked at all the randomized trials that compared calcium, vitamin D, and calcium and placebo on fracture reduction. And you can see the forest plot that most of this is the favoring supplements and control. Most of them are not favoring supplements, and their pooled estimate also did not. And this got a lot of attention in the press. There were a lot of articles in the Times saying, you know, calcium, so shocking news, calcium and vitamin D don't prevent fractures. The thing is, I don't think most of us really thought that calcium and vitamin D were treatments that we were going to use for patients who had fractures or were at high risk for fractures. They're necessary adjuncts, but by themselves, we would never use them to prevent fractures in high-risk patients. So I didn't actually think it merited all of the drama that it received, but it did certainly receive a lot, and we get questions every day from patients about this. And even the interpretation, the U.S. Preventative Task Force, I think, is still very much along the lines of what we all think, which is that it's recommended to encourage the use of vitamin D and calcium to maintain overall health, but there's insufficient evidence to support their use for preventing fractures. In terms of calcium and these potential risks that we're still not quite sure about, I think it is best to promote dietary intake of calcium for our patients. This is clearly the safest way. We don't see any evidence that there's any harm. And so we should suggest that our patients get as much calcium as they can from diet and then use supplements to make up the difference. It's especially important because patients who are deficient in calcium or vitamin D who receive bisphosphonates or denosumab are at high risk for developing hypocalcemia. And further, they may just not respond as well if they have a concurrent vitamin D or calcium deficiency to the medications. Okay, so let's revisit our case of Mr. Jones and his hip fracture. Okay. So we've determined that he has vitamin D deficiency. His level is actually 11 nanograms per milliliter. So what is our next step for treating him? Start a bisphosphonate, start denosumab, start an anabolic agent, or start vitamin D and calcium supplementation. All right, fantastic. Okay, good. So we all know this, and I think it's really important also practically for the patients they often need to make a lot of changes when we first see them. And this is always the first thing that I try to do because no matter what the next steps are going to be, we have to first achieve a state of calcium and vitamin D sufficiency before we go on to further treatment. Okay, so in conclusion, vitamin D insufficiency is widespread. It has clear skeletal sequelae. Supplementation can lower the risk of fractures and falls in deficient patients using optimal doses of about 800 units a day or maybe more. But there are potential risks with very high doses and with very high 25D levels. The inadequate intake of calcium is also very important for building and maintaining the skeleton, but there are potential risks with high doses of supplements. So the goal intake for our patients is 1,000 to 1,200 milligrams a day, and dietary sources are preferable when they can be used. Vitamin D and calcium are both necessary for skeletal health, and it is important that we encourage moderate intakes in our patients to maximize their efficacy and also to minimize the potential risks. Thank you.
Critical point that Emily made here, really important point, is that calcium and vitamin D by themselves will not prevent fractures. So when patients come in and say, well, why can't I just take calcium and vitamin D? I mean, this is the kind of data you say, it's an adjuvant, it's going to help, it's critical for your health, but it has to work in partnership with other medicines if you're going to lower the fracture risk. All right, we're going to go on to the next speaker, which is Kirsten Gruder. Kirsten runs our fracture liaison service, and she's going to introduce you to the concepts of patient-reported outcomes, or PROMIS. How many people in the audience have used PROMIS in their practice? Good for you, all right. So we have an audience that a new group, so let's see if we can convince you to at least educate yourself into what this can offer to you in your daily practice. So Kirsten, hit it.
Okay, good morning. So yeah, I've worked with Dr. Lane for the last 3.5 years, taking care of patients with fragility fractures and osteoporosis. So that's where we have integrated patient-reported outcomes into our practice. So go back to Mr. Jones, who comes to your office for a follow-up appointment 4 weeks after his hip fracture. So which of the following is an ideal component to assess his status? Contact his orthopedic surgeon to assess his postoperative functional status. Speak with his daughter about any physical limitations or complaints of pain, administer a short form questionnaire to evaluate his satisfaction with his medical progress, test his vitamin D if less than 15, maximize his supplementation, or give him a 25-item questionnaire on his health-related quality of life to complete and bring to his next appointment. Okay, so a lot of people chose D, or E, for that matter. The correct answer is actually C, and hopefully by the end of this you'll realize why. Focusing on information that comes directly from the patient, which both C and E did, but the short form questionnaire, which may be a little more realistic in terms of length and appropriateness. So we will go sort of through a couple of those points now. So when considering patient outcomes, you have a few different categories: clinician-reported, physiological, caregiver-reported, and then patient-reported. So as providers for taking care of patients with osteoporosis, a lot of people tend to focus on the objective data. So you're looking at T-scores, lab values, bone markers, and you kind of miss the category of patient-reported outcomes, looking at the patient's functional status, their overall well-being, health-related quality of life, satisfaction with treatment, and treatment adherence. So that's where we're going to see that there's room for growth in this patient population. So patient-reported outcomes are any report of the status of a patient's health condition, health behavior, or healthcare experience which comes directly from the patient without interpretation by a clinician or anyone else. So a patient-reported outcome measure then is a tool, a questionnaire, which is used to gain insight from the perspective of the patient. And these questionnaires give us the best source of information on symptoms such as pain, fatigue, and physical function, but then more importantly, how those symptoms impact meaningful activities in the patient's life. It also allows for us to look a little bit more about the patient's knowledge, attitude, and behaviors about their diagnosis and their treatment plan. So we know that there's variability and correlation between clinician and patient reports. We know that health-related quality of life predicts survival in many conditions, and we know that the same biological value in two patients does not always have the same impact. So two patients with a T-score of -2.0, one who has never had a fracture and one who has had a hip fracture, their independence level and depression, anxiety, fear of falling, all of those things obviously are very different. So patient-reported outcomes are measured through instruments, like I said, questionnaires. The overarching concepts are physical health, mental health, and social health, and then under each of those concepts there's several domains. For example, anxiety, pain, fatigue, physical function, and depression, which are these content areas, and then the items under each of the domains are the individual questions or statements. So patient-reported outcomes can be used in many different settings. In clinical trials, health-related quality of life assessment is required often for drug and medicinal product approval. There's a big opportunity in clinical care. It allows you to monitor disease progression and treatment interventions, detect physical or psychosocial issues which may not otherwise be apparent, improve patient-physician communication, and improve patient engagement in their own plan of care. They're feeling more part of the plan. It's also important to consider when defining quality of care. Payers and insurance companies often consider things like patient satisfaction scores when determining what is a high or low quality of care. So should you decide to integrate patient-reported outcomes into your practice, you have to figure out which measure you want to use. So this is arguably the most important part about using it, because you need to make sure you're measuring what you actually want to measure and what you think you're measuring versus, not. So responder burden is a big thing to consider when choosing this, because, in theory, a measure that covers 20 or 30 different domains and has many questions would be a fantastic source of information, but this is not always going to be realistic. And at the end of the day, something that's incomplete is not going to be obviously useful. So choosing the subtype of question, there are generic questions which measure domains that can be compared between different conditions and also between healthy populations. Or there are disease-specific questions which are developed specifically to capture elements of health and quality of life that are relevant to specific patient groups or conditions. So these are often more relevant to the patient, more appropriate, and often give you some more information about what your treatment plan is going to include. So the patient-reported outcome measurement information system, or PROMIS, was an initially NIH-funded initiative to develop and validate patient-reported outcomes for clinical research and practice. So for several years, independent researchers worked together to develop this psychometrically validated dynamic system to measure patient-reported outcomes efficiently in study participants with a wide range of chronic diseases and demographic characteristics. So it covers all of these bigger concepts of physical, mental, and social health. And there are over 300 measures used to collect data on it, which can be used in the general population and can also be particularly helpful for those living with chronic conditions. So if you choose to use PROMIS, you do so through the assessment center. So this is the web-based management tool. The website is at the bottom there, which enables creation of specific surveys and has participant interface for data collection. So if you go to the website, it kind of walks you through how, based on your specific institution. And as I said, it was initially NIH funded. It's no longer free. There are certain services that are free, and there are certain services that you have to pay for based on, again, where you practice. So PROMIS has created these electronic item banks of validated questions that cover a variety of domains. So the administration of these validated questions can be through either a short form or computer adaptive testing, which I'm going to go through the difference between both of those. So a short form is a fixed set of 4 to 10 items for one specific domain. So if you look here, these are examples of some of the domains. So for fatigue, there are 95 questions in the entire item bank, 95 validated questions. The short form is 7 questions, so you're only going to ask those 7 questions every time. Versus if you use computer adaptive testing, sorry, I didn't mean to do that. Computer adaptive testing, you have access to all 95 of those questions. So item response theory is a psychometric measurement method, which is a family of mathematical models that assumes responses on a set of items or questions are related to an unmeasured trait. So for example, for physical function, whether your physical function is high versus low, it assumes that your level on that scale will predict the probability of endorsing a specific item. So this is most effective when administered electronically, and it's one of the biggest strengths of the PROMIS system. So the computer adaptive testing utilizes this method, item response theory. So your answer to one question affects the next question administered, and therefore measurements are adapted to the individual. So it skips uninformative items to minimize the responder burden, and it allows determination of a person's standing on a domain without loss in measurement precision. So this picture kind of illustrates that. So again, back to physical function, if your answer to the first question is where number 1 is, your second question is only going to be within the range of 0 to 2, and then again, the third question will be only from 1 to 2. So it allows for a very high precision and a wide range. And it is, so these are some of the advantages of it. It's improved measurement precision across the full range of patient-reported outcomes. It's much more efficient because patients are not responding to questions that are irrelevant to their previous answer. More interpretable research with standard terminology and metrics. It can be used in international clinical trial applications, and it avoids the ceiling and floor effects, which are common to a lot of legacy instruments, so you don't have clustering at the top or bottom of the questionnaires. So some challenges for integrating this into your practice, your users have to be engaged, whether that's in clinical practice or in research. Both the subjects or patients and physicians or providers have to be engaged and have bought into the concept. The person administering the questionnaire has to be trained in PROMIS, and you need some infrastructure to effectively utilize this in the point of care, which is why many institutions are building them directly into the electronic medical record. So at HSS, patient-reported outcomes have been used extensively in patient registries for many years, and with the integration of Epic a few years ago, there's now a PROMIS 10, which is a short form, so it's the same 10 questions administered to every patient that goes directly into Epic. And then, we're working toward having disease-specific measures for all patients treated at HSS. So what your diagnosis is, you'll have a different questionnaire based on what you're being treated for. So Dr. Lane and our team did a pilot using patient-reported outcomes at HSS and mild corneal medicine in the setting of fragility fractures, so hip fractures. So we tried to use this item response theory and computer adaptive testing in-house. We brought an iPad to the patient's room a few days after a hip fracture surgery. It really did not work. There was a lot of dementia and delirium in these patients. They totally had no idea how to use iPads. They're all much older, taking a lot of postoperative medication, and there's a million people in the room screaming out screaming out answers, the daughters, caregivers, home health aides. So it didn't work. So we took a couple of steps to try to resolve this, which was, the first was using a 6-item screener, which is a validated tool to identify cognitive impairment and consent for participation in clinical research. So it's not a mini mental exam, but it's even more brief than that, just to do a quick screen of their ability to consent. So that eliminated a lot of patients. And then instead of using the computer adaptive testing, we did a short form. So the PROMIS 29, it's only 29 questions. It's on a piece of paper. And we administered so it's a generic health-related quality of life survey. So it assesses anxiety, depression, physical function, pain interference, fatigue, sleep disturbance, and your ability to participate in social roles and activities. So this was a lot easier for these particular patients to fill out and administer, and it gave us a lot of information on a bunch of different things. So we're administering this short form at postoperative day 2, so in the hospital, at 3 months and at 1 year. So we're still recruiting for this prospective study, but we're able to follow the trajectory of responses and then individually tailor patient care based on how the responses are differing. So the hypothesis is that we'll be able to identify specific trajectories and intervene in patients that are, going to be in jeopardy after a hip fracture. So looking at patient-reported outcomes in outpatient setting, we think that there's a lot more opportunity to use the computer adaptive testing and the item response theory. I think you have to be realistic on what setting you're in, and older patients may not be able to use the computer adaptive testing, but it is much more useful information. So right now we're using the PROMIS 29, again, which we said it's easy. It gives you a lot of information. It takes only 5 minutes. A lot of the older patients like it, but we do think that there's opportunity for some of the computer adaptive testing with an iPad in an outpatient setting in some of the younger patients. So the takeaways are that PROMIS is a powerful tool that can be used to phenotype osteoporotic patients beyond lab and DEXA values, where you're looking at when you go into the patient's room, you're not only considering their blood results and their bone mineral density, but also this third sort of score that you can trend every time that they come in. And patients really do enjoy being asked about their emotional and physical well-being. It increases patient engagement and their satisfaction. Their bone mineral density score or T-scores doesn't really mean anything to them. How they're feeling, how they're doing is really what's much more important, and it can allow for more feasible choices of drug therapy by identifying domains which may be barriers to compliance, because at the end of the day, you really just want your patients to be adherent to your treatment plan, and having them on board with the whole bigger picture, I think is a way to do that. Thank you.
We've identified, and we all know that things like depression, et cetera, will have an adverse effect on their outcome, particularly after fragility fractures and hip fractures. We're not very good at identifying it. I mean, a real seasoned clinician can talk to the patient and get a sort of a gist of it, but this gives you some numbers. And the other advantage that we're finding is that you can see people on a trajectory of getting better as time goes on, but if they suddenly start going in the wrong direction, you know that there's a problem afoot. And if it goes in the wrong direction, they stop eating, their compliance goes down. And this is a very simple way for you to do this technique. The group at University of Utah have really used this extensively. And when the patient comes in, they actually have the plot of these tests on every visit They look at it, and if it's flat or better, they're happy. If it's going the wrong way, they know they have to be a little bit more careful in interviewing the patient. Because maybe these are vague terms, but then if they're depressed, they're not going to do their physical therapy, they're not going to take their medicine, and so this offers a tremendous opportunity for you to follow your patients and get a sense of where they're basically going. Again, the issue about mental prowess. The people who get hip fractures, 40% of them have mental challenges. And this is a difficult crowd to deal with. But I think if you have a practice with younger people, 50s and 60s, these people whip right through this system very well. And then they think you're at least paying attention to issues of importance to them. Whether your T-score goes up or down, or these are vague terms to them, but they understand how they're feeling. So we'll get back into that. So I want to go through a series of questions that have come up, and I'll try to go in order, Richard. So I think I'm going to start going off with you regarding men. Was your data, some of your information on the trabeculae, this all came from the high resolution technique. They asked that question. The question is also, if you are going to do elective surgery, how important is this particular, in men, if you're going to do a hip replacement, how important is to know about this thing? There's an issue called periprosthetic fractures. Should we be evaluating the bone in the patients we're going to do a bony procedure on? And particularly among men as well as women.
Oh my God, that's virtually becoming our mantra at HSS and the goal of the metabolic bone service is there are so many studies that clearly document that you get improved outcomes in patients if you make them metabolically healthy before you do surgery. And there's such a pressure now to have patients have a procedure and move on out of the hospital, rather, so that it becomes even more critical. I think there's no question that you improve outcomes if people's calcium, vitamin D, et cetera, are all in very good shape. We also have very stringent criteria, by the way, of who gets in to have elective surgery. For example, you have to have a hemoglobin A1C that's 8 or less. This has had a terrific benefit. Not all of us, exist in sort of an elective facility where patients are screened before they come in to make sure that they're suitable and ideal. But I think this is where we're going, and we need to go there because we do end up with better outcomes if we're not operating on people who are morbidly obese, who have terrible pulmonary and cardiovascular problems. I mean, obviously in the general hospital where we also work, sometimes our hand is forced, but there's no question that a metabolically stable, improved, cared for patient does better in all of these procedures.
I think the point that Rich is bringing out is that we've seen a big change at our institution. Orthopedists thought that you could do it with heavy metal or more heavy metal, and they suddenly realize that they have some failures. Even they admit they have failures. And the question is, who are these people who are failing? And they recognize that many of them have metabolic defects. Like Brinkley showed that low vitamin D is one of the reasons people get non-unions. So they've slowly come around to realize that maybe if we have a better prepared patient to undergo surgery, we will end up with better positive results. And so there is an unbelievable partnership now between the people who are doing the procedures. They want their endocrinologists to better prepare their patients. And I think we need more communication in this. I'm not saying it's only orthopedists, neurosurgeons, people who do foot stuff and hand stuff, whatever this is, anything that requires the bone to heal would benefit from at least addressing these issues. Now, the question with men, notice that it's hard. How do you handle the issue to going up to a gentleman and saying, you have osteoporosis. Is this well taken or not taken well?
Oh, it's an interesting problem. And, it's as an endocrinologist, the responses that you get, similar in the bariatric patient population, when you tell a patient that maybe they want to consider a bariatric intervention, and they look at you and they say, "Me?" And it may be obvious to you, but it's unfortunately not so obvious to them. The problems in metabolic bone are far more subtle and difficult. Very often, the patients that we're seeing at HSS have already had a fracture. If a patient has had a fracture, you're already sort of moved up in the game, and they tend to be more responsive and listen. We had a funny circumstance where we were doing an outreach program where we were invited people to come and be screened, and it was sort of a picnic carnival setup. And the local House of Representatives came, and his wife got up on our DEXA machine and was screened, and she turned out to have terrific bone density. She turned around to him and said, "Now, honey, it's your turn." He almost had a hemorrhage, but he did get up on the machine, and he had terrible bone density. So that's how we recruit our patients. Bring
Richard-
your wife.
Richard, one last thing. Smoking, is that an indication for doing a DEXA?
It's definitely undesirable because there's no question that smoking interferes with bone healing. So for patients who are coming in, we strenuously try to discourage smoking and a number of other habits. As for an indication for screening, I think it is, because I think these patients tend to be thinner and less healthy.
So Emily, it's your turn. What about, what do you regularly measure PTH when you're looking at the calcium and the vitamin D? Is this part of your system, and how do you use the PTH?
Yes, I do. So I initially, when I see patients, I always get PTH. And I do look at that. And, I think a lot of times now people know about vitamin D and they're taking D and, maybe very confused about calcium, maybe have stopped all calcium because they think it's going to give them a heart attack, or now they've read that it's not going to prevent the fractures. So they're often calcium deficient. And you see that in the PTH elevation. So it's very helpful as part of the overall assessment of their calcium and vitamin D status, because it's, it's showing you another endpoint. So, as in the studies where they define vitamin D deficiency by how it impacted PTH, I think clinically we can do that as well. And if a patient has an elevated PTH, you want to understand why, and maybe it's primary hyperpara, but if the calcium's normal, certainly it's most likely to be then related to an inadequate calcium, vitamin D, or some renal insufficiency. So I always do it. If I have it that it's normal and I've optimized their calcium and D, I don't keep checking their PTH. I don't think you have a benefit from that.
So there's a series of questions that came up about actually the technique of testing. Do you keep them NPO? If a person's been on an anabolic agent, do you have them stop the calcium before? Is there diurnal? When is the best time to test it? Do you have some tricks as to how to test these patients?
So I just for consistency, I have all of my patients do their blood first thing in the morning fasting, and that way I don't have to remember on a day-to-day basis what I'm trying to measure, whether I'm getting bone turnover markers, which are affected by time of day and food intake, or that's just how I do my labs, and it makes it easier. So I do have them do it before they're taking supplements first thing in the morning.
They asked, a series of questions came up about people with a history of kidney stones. How do you start? Is there a role for calcium? What kind of calcium? How do you protect them when should they get calcium if they've had a history of kidney stones?
So I include 24-hour urine for calcium in my initial assessment as well, so I know exactly where I'm starting from and how comfortable I feel and how aggressive I can be in terms of calcium, and also vitamin D, because that will affect it as well. I think in those patients, it's even more beneficial for them to be getting calcium from diet when they can, and as much as they can from diet, which really is not going to cause the same risk of hypercalciuria and worsening stones. There is a study suggesting that calcium citrate is less likely to promote stones than carbonate. So I think you could try going to citrate, but really the dietary, or at least a large portion of what you're recommending to them in terms of intake from dietary is the way to go with patients like that.
Richard, you had some comments?
Yeah, I'd like to comment on that because we actually published a study. We had 21 or 25 women who had low bone mass. Remember, if somebody's suffering with hypercalciuria and forming kidney stones, they're leaking calcium, and usually they're told not to take calcium, so they're calcium insufficient. And the patients we were looking at had very low bone mass. So we were concerned with that population of patients. What we did was we did stone risk profiles on these patients, and we followed them over 2 years, supplementing them carefully with calcium citrate. Interestingly, only one patient showed a slight worsening of her profile with calcium. All the other patients showed no adverse effects and no kidney stones, thank goodness. Interesting, I won't go beyond that, but the point is that I think there is a need with close monitoring, to provide calcium, preferably in a soluble form, to patients who have, even if they've had prior history of kidney stones.
So I'm going to finish up with some questions for Kirsten. They asked the question, can people outside the United States use the PROMIS? What are the costs involved with it? And what would be your recommendation? If you want to get started, what should you do? I mean, what are the steps that you should do to try to get yourself started on this?
Yes, it is available internationally. The costs are different per institution, so you kind of have to call. If you go on that website, the assessment center, it will walk you through how to integrate it into your own practice. If your institution has participated with the integration into Epic, like we have Epic, there's a much lower cost. The short forms are free to use, but all the computer adaptive testing, I think if you want to have an iPad, you download an app that's $500 a year.
How much?
$500 a year. And then that also includes the interpretation, like the scoring. They give you T-scores for all of the results. But it's different based on every institution, so I don't exactly know how to answer that. And what was the last question?
The other question, a related question is it only in English, or are there other languages
There's
that you
all different languages, translated into many different languages.
So the question is, is there some resource that they can actually go to to
that
get a tutorial to get themselves started?
The Health Measures Assessment Center. That's what it's called. It's a website.
My recommendation is somewhere in your institution is somebody using the PROMIS. Probably the rheumatologist, some of these other, and I would become friendly with them, and we learned from the rheumatology service. They came in and helped us enormously. So I think the average person in their office can easily use this system, and it will help you. First of all, your patients will love you. And secondly, when they come in, you'll avoid a lot of questions because they've already been answered. But most importantly is I think you'll do a better job. You'll recognize people in need of help, and you can then tailor your issues to those particular problems. The question is, let's see, I think we've covered most of the things. How often do you think you should do the PROMIS as a minimum? And one person say, why not do it more frequently when you're doing changes in treatment or changes in a disease? Do you think waiting a year, is that going to help you, or should you do it on a more regular basis?
I mean, I think that if it's easy enough when they're in the waiting room, I don't see why you shouldn't just do it every time they come in, if it's going right into Epic. So the idea is that you'll get a score, each time they come in. So in addition to looking at their bone density, their labs, you also have this score to trend, and you can see if it's correlated. I predict that oftentimes that may not be correlated with their changes in bone mineral density. how they're feeling and how their functional status is. But it's another metric used to determine their overall progress.
Somebody asked a question about reimbursement. It's in your level of how you're encountered with the patient. I think if you have this part of this information in, there is some, it really doesn't take more time for you. Yeah. They're doing this in the office before they come in.
Out before they even see you, so.
Okay, well, we're going to go. We want to thank our panel at this time. We'll stay around for some questions afterwards. And you need to fill in your documentation at the end of this to get your CME credit. You can get your notes back if you've asked questions. You have homework today. Think about the things that I want you to look for men. Certainly Emily has got you to think more carefully about the tops and the bottoms of calcium and vitamin D. And I think I want you to find a friend, call your friend, call a friend with PROMIS and see if this has some interest to you and watch how they basically use it in your environment. I'm sure in your environment there's somebody who's doing this today. And I want to thank the CME group that put this together, and have a good day at the rest of the meeting. Thank you.